So now we will be discussing the vertical jaw relations, as we have already discussed about the orientation jaw relation, what is jaw relation, and before going on forward to the vertical jaw relation, let us discuss the clinical significance of jaw relations in edentulous patients. What is the clinical significance is to reestablish the functional position of the mandible, comfort, aesthetics, phonetics, functional efficiency, structural balance. So all the factors which are important, it will when the jaw relation is properly recorded, it will produce a proper neuromuscular harmony and balance in the oral musculature, and it will directly affect the aesthetics and phonetics of the patient's mouth. So what is vertical dimension? Vertical dimension is the amount of separation between the jaws, and it is essential in the successful practice of many phases of dentistry. Greatest cause of complete denture difficulties is failure to restore the lost vertical dimension to normal. Because of the loss of the teeth, the vertical dimension is lost, vertical dimension of occlusion is lost. So that occlusal, that lost dimension should be restored to the normal with the help of the jaw relation, at the time of application of complete dentures. And if it is not done properly, then that is the most common cause of the failure of the dentures fabricated. So this is the jaw relation again. The definition of vertical dimension is the distance between two selected anatomical reference point or marked points, usually one on the tip of the nose and other on the chin, and one on a fixed and one on the movable member. The single most important factor in determining the vertical dimension in edentulous patients and in the edentulous arches is the mandibular musculature. So the vertical dimension can be classified as vertical dimension rest and vertical dimension occlusion. Rest vertical dimension is the length of the face as determined by amount of separation between the jaws, and it is distance between the two selected points, which is one on the middle of the face of the nose and other on the lower part of the chin. That's the most prominent part of the chin, and the distance between these 2 points when the mandible is in the physiological rest position will help us to determine the vertical dimension at rest. So vertical dimension at rest is the length of the face when the mandible is in the rest position. That is the vertical dimension of the rest, and it is dependent on the so first now we will discuss the physiological rest position. It is the mandibular position assumed when the head is in an upright position and the involved muscles. What are the muscles involved? Particularly the elevator and the depressor groups are in equilibrium in tonic contraction, and the condyles are in a neutral unstrained position. Another definition is a position assumed by the mandible when the attached muscles are in a state of tonic equilibrium. This position is usually noted when the head is held upright. And another definition is a postural position of the mandible when the individual is resting comfortably in upright position and the associated muscles are in a state of minimal contractual activity. So in all these definitions, we can easily see that the most important point is all the muscles which elevates or depresses the mandible, all the muscles are in a state of minimal tonic contraction. They are in tonic equilibrium. So that determines the physiological rest position. And similarly, the vertical dimension of occlusion will be the distance measured between the 2 points when the occluding members are in contact. So when the occluding members, whether it is teeth, whether it is rims, they are in contact with each other, at that point, the vertical dimension will be the vertical dimension of occlusion, and rest will be then at the physiological rest position, we'll calculate the vertical dimension of rest. That means all the muscles will be in the state of tonic equilibrium. Repetitive contracted length of the elevator muscles determines the vertical dimension of occlusion. And so the interrelationship between the vertical dimension rest and occlusion will help us to calculate the freeway space or intraocclusal rest space. The difference between the vertical dimension rest and vertical dimension while in occlusion gives us the freeway space, and it is necessary to restore this space while we are fabricating the dentures so that the muscles can be allowed to stay in a state of rest, and this is very important step in the freeways, giving freeway spaces in the dentures to allow the mandible to be in the rest, to allow the ridges to be in the rest, to produce a free time for the ridges and the mucosa. Postural rest position is influenced by the position of the lower jaw. A range of posture rather than a single rest position is usually noted. Postural rest position is further influenced by the position of head. Upright, unsupported held while records are made is the key. So, what is the postural rest position? The see this well, like the patient can be at rest. Like a rest position of the patient can be dependent on this posture, and posture is influenced by the position of the lower jaw. So it is not there is a range of posture. It is not that this posture is at rest or this posture is at rest. There is a range in which the rest position is created by the posture. So postural rest position is further influenced by the position of the head. So while recording the rest position, vertical dimension of rest, physiological rest position, we need to see that the upright, unsupported head while records are made is the key to determine the vertical dimension of rest. What is the significance of physiological rest position? It is a bone-to-bone relation. It is fairly constant throughout the life, and acceptable limits while recording is made is permitted, and it is used to determine the vertical dimension of occlusion. So we see that the vertical dimension of rest is determined by the what are the factors. Then this Dawson has given a 4-pointer to understand the vertical dimension. So vertical dimension first it is influenced by the musculature, mandibular musculature, and when the vertical dimension of occlusion is influenced by the teeth, they act as a vertical stops, and then the in dimension of rest, musculature in the state of tonic equilibrium determines the vertical dimension of rest. So we need to why we need to determine the vertical dimension of rest and fabricate the dentures in the same, because when the in the long period of edentulousness, the patient he has the habit, he goes to the habitual rest position. So the two and if we are fabricating the dentures in the habitual rest position, then the dentures will not be comfortable for the patient, and we need to restore the physiological rest position while fabricating the dentures. So it is very important step while fabricating the dentures, the vertical, determining the proper vertical dimension. You cannot determine the vertical dimension based on whether the patient is comfortable. Measuring freeway space is not an accurate way to determine correct vertical dimension of occlusion. Determining the rest position of the mandible is not a key to determine the vertical dimension, and lost vertical dimension is not a cause of temporomandibular disorders. This was a Dawson's 4-pointer given to understand the vertical dimension. So what is the importance of vertical dimension? Importance will be it will help in the restoring the aesthetics, it will help in functioning, it will help in the structural balance, it will help in the psychological role, like the and it will help in the comfortable role by maintaining the health of the mucosa. So we were discussing the this advantages of importance of vertical jaw relation. It has a psychological role in the patient. It gives a comfortable role. It reduces the resorption of the ridges by maintaining by health of the tissue, mucosa, bones, muscles, and temporomandibular joint. And it has an aesthetic role. When the lost vertical dimension, we are restoring the lost vertical dimension. So the musculatures and the skin around the oral mucosa is in the pleasing position. So aesthetics also it restores, and the next is the functional roles like the functional procedures like the deglutition, swallowing, deglutition, mastication, respiration, all are restored with the when we restore the vertical dimension. So what are the history and references? History of the vertical dimension. Like in 1771 is when the Hunter described the range of motion of the muscles and ligaments surrounding the joints of the body. Walish in 1996 was the first to define the physiological rest position, and Thompson and Brody 1942 stated that the position of the mandible in relation to the face and head and proportion of any face as far as vertical is concerned and is constant throughout the life. These are the various scientists who described the range of who described about the vertical jaw relation, like the physiological rest position was first described by the Walish, and the Hunter described the range of motion of the muscles and ligaments. So constancy concept of face height. This concept was given by Niswanger 1934. The neutral position is the equilibrium of the opening. What is a neutral position? In which there is equilibrium of the opening and closing muscles. Tonic equilibrium of the opening and closing muscles. And the jaw relator is a gauge to measure the vertical dimension of the face. The 200 dentulous patients were studied, and a conclusion was made that teeth slowly wear down. Nature makes the necessary changes in the bone and the soft tissues to maintain a particular interocclusal clearance. He correlated these findings in the edentulous individuals to find the effects with the change in the vertical and denture success. What is the role of muscle physiology in this? Mershon, he contended that the muscle cannot lengthen to accommodate an increase in bone size, but rather bone adapts itself to the length of the muscles. And Schlosser in 1941 came up with the importance of phonetics and determining the vertical relation. Identical rest position was achieved by sounding the letter M again and again. So these they have given the role of muscle physiology in the determination of vertical dimension. Like muscle cannot, Mershon said that muscle cannot lengthen to accommodate an increase in bone size. Muscle length will remain the same. It is the bone which is adapting to the change in the muscle. Uh, and then he came with the Schlosser came up with the importance of phonetics. He said that the by repeating repetitive sounds like M sound can help us to determine the vertical dimension. Varied school of thought like regarding the vertical dimension is the Harrison height. He reasoned that vertical dimension of occlusion was dependent on the occlusal contacts and the closing movements of the mandible. Hence, abrasion of the teeth, resorption of ridges make the correct vertical opening in the edentulous debatable. He said that vertical dimension is only dependent on the occlusal contacts and the closing movements of the mandible. And when there is resorption of ridges, then how could we maintain, restore the same vertical dimension of occlusion? And then Olsen, Atwood, and Talgreen, they use longitudinal radiographic analysis and cephalometrics to show instability in the rest position after removal of the teeth. As we discussed, this position is constant, and so there were different schools of thought regarding the constancy and the of the this physiological rest position, and they did different studies to and like the Olsen, Atwood, they did the radiographic study to show the instability in the rest position. Fordlow in 1964, he did the cephalometric study in immediate denture patients over a period of 6 months. And the transition period of dentition showed phonetic method was more reliable than the swallowing method. VDR and video increased initially and then decreased markedly in 6 months. And then the intraocclusal distance is self-adjusting. It is the intraocclusal distance which is adjusting itself because it is in the range of 2 to 4 mm. And vertical and dimension rest and occlusion are changing. He said that and mandibular load is influenced by the rest position. What are the methods? Now we will discuss, as now we have discussed the vertical dimension. And in the vertical dimension, we have discussed the vertical dimension at rest and vertical dimension of occlusion. And the freeway space is given in the by restoring the occlusion at vertical dimension of occlusion. Like means we are arranging the teeth at the vertical dimension of occlusion, and we are at the by giving the freeway space because vertical dimension of occlusion is 2 to 4 mm lesser than the vertical dimension at rest. So factors which are considered for the rest position is the position of the mandible is influenced by gravity. So the patient should be seated upright like the postural position we discussed. It is very important. The head posture is very important in determining the vertical dimension. If the patient is seated comfortably, then it is not like the patient is in a comfortable position, then only we could determine the vertical dimension rest. It is the head posture which determines because the position of mandible is influenced by gravity. So patient should be seated upright or standing with the head erect, looking straight ahead in the front when the jaw relation records are made. So patient should be calm, cool, and relaxed when the jaw relations are recorded. Neuromuscular disturbances make the record difficult. With these patients, the operator must be very considerate and cool. So dentists should be prepared to make the measurements without delay when the position is assumed because the rest position is not to be maintained for a duration period of time. So we discuss the posture also, and also the patient should be calm, cool, and relaxed when the jaw relation made. They should not, if they should not be in the like the stressed position when their patient is stressed, and then also they, it will be difficult for the dentist to determine the vertical rest position, physiological rest position. They should be cool, calm, and composed. And neuromuscular disturbances also makes it records difficult. The operator must be very patient must be considerate and cool. Dentist should be prepared to make the measurements without delay, because it is this is a position which cannot be maintained for indefinite period of time. So it should be recorded as soon as possible without delay. And no one method. We are determining the rest position by functional methods, like we are using the phonetics as a method. We are determining with the help of facial landmarks. So no one method can be used accepted as being valid for all the patients. So several methods are available to confirm this record. So we take the average of two or three methods, average readings of two or three methods, and determine the this vertical dimension of physiological rest position. Methods can be mechanical, physiological, and aesthetics. As a guide combines the use of both the methods. The mechanical method, this the ridge relations is one of the method in the mechanical method. So parallelism of the ridge, it is said that when in the vertical dimension of occlusion, the ridges, maxillary and mandibular ridges will be parallel to each other, and there will be 5-degree opening the posterior region. This was acceptable, and this was suggested by Sears. Sears has suggested that method, the parallelism of ridges, but this method is not accepted or not valid, because it is not necessary that all the teeth must have been extracted at the same time. Also the resorption, so the resorption must have pattern must also be different. So it is not necessary the ridges will be parallel to each other, and marked resorption of the ridges make this rule void. And also another method in the mechanical method is the distance of the incisive papilla from the mandibular incisors. See this, there is the from the incisive papilla is a stable landmark which does not change its position even with the resorption of the ridges. So we are using it as a landmark to determine the vertical dimension. And this the vertical dimension of occlusion, like in this distance between the incisive papilla and the incisal edge of the maxillary incisors is 6 mm. And this and the overlap, horizontal overjet is around, a vertical overlap between the upper and lower incisors is around 2 mm. So that gives a distance of 4 mm, like this. So distance between the incisor papilla and the mandibular incisors is 4 mm. So when the teeth are in centric occlusion, incisal edges of the mandibular central incisors are on average 4 mm from the incisal papilla. So this distance can be used as a guide in determining the vertical dimension of occlusion because of the incisive papilla, which is a stable landmark. Next method is the measurement of the former dentures. Measurements are made from the intaglio surface of the dentures on the corresponding crestal surface of the ridge. Like the patient has in previous dentures, the recordings are made, and these recordings can help us to determine. This is an instrument which is used to measure the horizontal or vertical relationship of the incisor papilla landmark on the denture to the incisal points. Alma gauge, pre-extraction. Pre-extraction measurement of the former dentures can be used. In this, we are using the incisor papilla as a landmark in the determining the dimension with the help of former dentures. And with this gauge, we are determining the measurement with the help of the intaglio surfaces of the dentures. The pre-extraction guides. One can also usually establish an occlusal position, record and transfer to the indenturous situation. There are several ways, like the profile photographs, profile radiographs, profile photographs. Lateral skull radiographs before and after extraction with trial basis. Comparisons helps to bring the necessary changes in the positions of the mandible. But this method is not much valid because of superimposition of the images, and so it is very difficult to calculate the exact measurements. Profile photographs, like when the profile photographs made with the teeth in occlusion when the teeth were present, and we need to make the photograph while asking the patient to make the teeth contact in the maximum occlusion. And then the measurement of the anatomical. Now this photograph is enlarged to the patient face, enlarged to the size of the patient face, and then the anatomical landmarks are measured on the photographs are compared with that of the patient's. And when the record are made and the trying is done, this can be This method has a disadvantage of angulation of the photo might differ. Photo enlargements can cause inaccuracies. So the photos which were taken before the edentulous, when the patients were having the teeth in the occlusion, and they are enlarged to a size and compared with the anatomical landmarks now with the patient face after losing the teeth. Another method is the profile tracing the Stillhouse. This is the lead wire adaptation along the midline helps prepare this lead wire adaptation along the midline of the face in this profile. They help us preparing a cardboard cutout. We now prepare the cardboard cutout, which is preserved after extraction. Vertical estimation done by matching the new profile with the cutout. So this cutout is prepared before extraction of the teeth, and then this cutout will help us to determine the vertical dimension of occlusion by keeping this along the by matching the new profile with the cutout. Another method is the articulated cast and models. See this articulation of cast to correct anatomic position with the faceboard transfer before and after the extractions help in the interarch measurements. So we need a faceboard transfer for this, and also the cast should be articulated to correct anatomical positions. That can be done with the help of faceboard only. So that is the main requirement in this method. And also we'll fabricate first, we'll mount the patient cast before losing the teeth in the when the teeth are in the mouth, and then we will compare it with the when the patient will lose his teeth and the edentulous face. We'll mount the cast with the help of Facebook record, and then we will compare the interarch distance, like before when the teeth were present and after the loss of the teeth. So, but long period of fabrication and excessive bone loss during extraction might limit its use. Another method is a dacometer. Bennett's dacometer, made by Elliott Brothers in London during 1929 to 35, it records both the vertical dimension with natural teeth and the position of the central incisors. It consists of the nose and the chin piece, which are secured with a compound to measure the readings on the spring gauge. It has a nose piece and the chin piece, which are secured with a they are secured. This is a compound, you can see they're secured with the compound, and they help us to measure the readings on the spring gauge. The dacometer is a device, dacometer. Will's gauge can also be used. Facial measurements. In this method, we are using the facial measurements as a guide to record the vertical dimension of occlusion. So in this, like the Will's gauge, Will's measurement, the distance between the lower border of the septum of the nose to the lower border of the chin is equal to the distance from the rima oris, outer canthus of the eye, to the corner of the mouth in the rest position. This is the device that is called the Will's gauge, and these both measurements are compared and they should be equal. Disadvantage is the inaccuracy, as the degree of pressure applied may not be same every time. See, this will calculate the distance between the lower border of the lower border of the septum of the nose to the lower border of the chin. This calculated distance A, and the distance from the outer canthus of the eye to the angle of the mouth is calculated distance B. So this facial measurement can be used as a guide in determining the vertical dimension of occlusion. Another type of gauges are like the Venus gauge, Apollo gauge. Facial measurements can also be done through tattoo points, but before extraction of the teeth, before extraction, we'll make the tattoo and mark the facial measurements, and after extraction of the teeth, after the loss in the edentulous phase, in the dentulous phase and edentulous phase, we'll compare the facial measurements using the tattoo points. But this could possibly be the most phased out technique for the because patient will not be comfortable with the permanent tattoo. Another method is acrylic face mask. They're made before extractions and verified when the patient is rendered edentulous. This like made before extraction, and then you will verify it when the patient is rendered edentulous. But it's a time-consuming procedure, requires a lot of skill and experience, and also with the posture, different topography of the face in the erect and the recumbent posture. Also, anterior teeth can be used in determining the occlusal vertical dimension. We are all in these all methods. We are determining the vertical dimension of occlusion with the pre-extraction records. We are using the pre-extraction records, like we use the facial measurements as a guide. We use the pre-extraction photographs, and we use the pre-extraction radiographs. Then the ridge relations we use the before extraction, and then we'll use the anterior teeth are also in determining a polyethylene impression of the mucolabral reflection of the upper and lower lip and the labial surface of the left to right canine is made. This impression of this whole surface is made with the help of polyether impression material. The width in this, we are making the impression from the mucolabral reflection of the upper and lower lip till the teeth. And this distance from the height of the mucolabral reflection to the upper lip to the tip of the anteriors are reproduced in the artificial dentition. And thus we'll try to reproduce the same measurement as obtained from the mucolabral reflection on the upper lip to the incisors, and we will try to reproduce in the artificial dentition. Direct procedure for indicating mandibular rest position. L-shaped wire is attached to the skin on the mandible protuberance. A vertical millimeter scale is fixed to the stationary headgear. Mean value of opening and closing exercises until the lips just touch either act as a reference measurement. Height of the mandibular rim is adjusted accordingly. This is a direct procedure for indicating mandibular rest position. Like this, opening and closing exercises are used as a guide to determine the vertical dimension, and the height of the mandibular rim is adjusted accordingly. Now we will do the post-extraction measurement. After the extraction, how can we measure the vertical dimension? How can we do the measurements? So the campus plane or hilar tragus line and the interpupillary line are the hallmarks of the procedure in the Niswonger's method. And upright position leads the plane to be parallel to the floor. First, the patient should be seated upright, and then using the Fox plane, we will see the campus plane and the interpupillary plane are parallel, and the markings are made on the tip of the nose and the most stable area of the chin. Okay, like this, with the help of any this paper, with the paper with the micropore tape, or with the help of it from this markings with the help of the marker, we can mark the point on the nasal tip and the most prominent point of the chin, because they are the most prominent stable landmark. So distance between the marks is recorded as the patient is asked to swallow and relax. Subsequently, occlusal ribs are fabricated so that when they occlude, they have a measurement of 1 to 8 mm less than the original measurement. This 1 to 8 inch average gives a freeway space of 2 to 4 mm. See this, what is the main concept of the Niswonger's method? We'll use, in this also we are taking the facial measurements, and we'll mark the points on the tip of the nose and the most prominent point of the chin, because they're stable landmarks and they will not change with the patient, with the change of the facial profile. Like patient is in a relaxed position or in the contracted position, these positions will not change. So we'll mark the points on these landmarks, and then we will record the distance between these marks asking the patient to swallow and relax. And in the relaxed position and then the swallowing position, we'll ask the patient to perform such movements, and then we'll record the distance. And this distance, and therefore with this distance will make us help us to determine the vertical dimension rest. And subsequently the occlusal rims are fabricated such that there should be 2 to 4 mm space lesser than this distance. Boole's biometer or PowerPoint device. Boole's in 1940 found that there's a recordable point of maximum biting power. The device used is known as biometer, which is a type of spring gnathodynamometer. Biometer is attached to the mandibular record base and metal placed to the vault of the maxillary base for the central bearing point. The attached gauge indicates the pounds of pressure generated during closure at different degrees of jaw separation. Maximum point is locked, maximum pressure is locked, and the plaster registration made and transferred to the articulator. This is the Boole's biometer gauge, and in this we are using the biting force to record the vertical dimension. And this assembly is attached to the maxillary mandibular record base, and as the patient bites, and it is recorded with the help of this spring gnathodynamometer, and the maximum pressure is, so maximum point is locked, and the plaster registration made and transferred to the articulator. Another method is the neuromuscular perception method. This is the Lyle's neuromuscular perception. In 1964, this method was given by Lyle RB 1964. A central bearing device is attached to the accurately adapted record base. It relies on patient perception of different vertical height. See this central bearing device is attached to the patient record base, accurately adapted record base, and this bearing pin is adjusted beyond the rest position. Okay. Now we will lower the this bearing pin is then lowered by half ton, and patient has to signify the overclosure. Pin is drained again until excess opening is done. See this, as soon as the pin is open, so the patient mouth is open, and we will lower down the rim slowly as soon as the patient will feel like he has reached in a comfortable position, in the rest position. So we will do it again till excess opening is seen, and approximate vertical relation is then judged by the patient, because this method is dependent on the patient perception, patient neuromuscular perception, like he feels now, yes, now he is in the rest position. So we will using this device to for patient to analyze this for the patient to analyze this comfortable position, this stable position. Disadvantage is if the patient with a poor neuromuscular coordination cannot be it cannot be used in such patients. So this was the neuromuscular perception method. This is a Booth biometer PowerPoint device, and next is the electromyography. With the help of EMG activity also, electrical activity of the masticatory muscles also, we can determine the vertical jaw relation. Neuromuscular dentistry has found an important position in prosthodontics. The rest position of mandible can be determined by means of EMG activity. As a stable reference point may be achieved for recording vertical dimension values. Disadvantage with this method is expensive with complex apparatus is required and adequate knowledge is required. See, this is such a complex apparatus, and a stable reference point may be achieved by this method. See this rest position test. How we'll check the rest position is patient is in the rest position or not. This is one of the routine exercises where an intraocclusal rest space of 2 to 3 mm is noted in the premolar region. Again, indelible dots or adhesive tapes on the reference points are marked, and we will check the rest position by we will see in the when we will okay. We have determined the vertical dimension of rest, like it is around 10 mm. So we'll fabricate the rims, keeping in mind the freeway space of 2 to 4 mm by 6 to 8 mm. With the dimension of 6 to 8 mm vertical dimension of occlusion, we'll fabricate the rims. So when we will see, we'll ask the patient to repeat some sounds or to talk to, and then we will try to notice some space 2 to 3 mm is trying to notice the space of 2 to 3 mm premolar region. These are the rest position tests. And too high vertical scene if the interar space is less than 2 mm. Too low vertical scene is space is more than 4 mm. So phonetics can be used as a guide to determine the vertical dimension rest as well as occlusion. And but for determining the vertical dimension rest, we'll ask the patient to repeat the letter sounds M. And as soon as he stops as soon as the patient lips just parted, just in contact with each other, then we will make the measurements. And also phonetics as a guide can be used to determine the vertical dimension of occlusion by Silverman's method. In this, the certain sounds like S, Z, sh, j, ch, che, as in buzz, fish, church, brings upper and lower anterior teeth very close to each other. And the correct position placement of lower incisors makes them directly under the upper member during this exercise. When the patient pronounces the letter S, then the lower teeth will slightly come in contact with the upper member. So this position is taken as a guide. This sound is taken as a guide in determining the vertical dimension of occlusion. Like when the patient is pronouncing these letters, can we see such space? Can we see they are approximating in with each other, upper and lower rims? So then that can be used as a guide. And also the position of tongue is evaluated. The phonetics is a very important method which can help us to determine the vertical dimension. Like the patient is asked to pronounce the letter 33, and the tip of the tongue will protrude between the anterior teeth when the patient pronounces 33. So if all these are happening properly, this phonetic test is conducted properly, then we see that we have recorded the correct vertical dimension. The Silverman method of phonetics method, it was originally evaluated natural dentition by Silverman. The reference lines are marked on the lower anterior teeth with respect to the artificial dentition, keeping the labial thickness of the occlusal rims as at a natural denture teeth is important. We'll adjust the lip support, and the closest speaking space is adjusted until a minimum of 2 mm space is achieved when the patient pronounces S. Also, the rest position can be measured by facial expressions as a guide. Vertical dimension rest can be judged by number of facial details. Like in normally related jaws, the lips will be in even contact, will be even anterior posteriorly in slight contact. Lips will not be strained. Lips will not be loosened. So this can be used as a guide. Patient with a retruded mandible has uneven lip position and the two are not in contact. Vice versa is observed in case of prognathic mandibles. Skin around the eyes and chin should be relaxed. Relaxation along the nares reflects the unobstructed breathing. So this was the method of the facial expression used as a guide in recording the vertical dimension. So in normal related jaws, the lips will be evenly contacted. So in this method, we will use the facial expressions like the skin around the eyes and the chin should be relaxed and should be patient position, profile should be straight, and all these expressions can be used as a guide. Next method is the swallowing threshold. At the beginning of the swallowing cycle, the teeth come together with a very light contact. This technique involves building, like we have built the cones of the soft wax on the mandibular rim, and the patient is asked to perform so that it contacts the upper, these soft cones of wax are fabricated so that they contact the upper occlusal rims, and with the jaws wide open. And the flow of saliva is stimulated, and the repeated action of the swallowing will gradually retreat. We'll ask the patient to swallow again and again. It will gradually reduce the height of the wax cones to allow the mandible to reach the level of the occlusal vertical relation. Another method to determine the vertical dimension of rest is the tactile sense. In this method, neuromuscular perception is act as a guide to describe this method, act as a reference to determine. And this central bearing device may or may not be used for determining the correct vertical. The patient neuromuscular coordination is important. It might not be useful for senile patients or one with the improper neuromuscular coordination. Like the patient is asked to repeatedly open and close the mouth, and as soon as and they will open and close, then as soon as uh, they will stop this movement, then the mandible will come in the physiological rest position, in the comfortable position. So tactile sense can be used as a guide. It can be used as a method in determining the vertical dimension. Another method is like the centric tray BPS, Ivoclar, or Ivadine. One of the latest techniques is to record the trial vertical relation, making use of the centric tray with an irreversible hydrocolloid at the recording medium as the recording medium. In trying procedures, also we can determine the vertical dimension after taking the jaw relation and mounting the rims in place, and then the rims with the trial record basis might act as an important aid in determining the vertical. But the importance of wax of teeth can also be not to be underestimated. Trying of a complete denture should be a detailed appointment where the vertical relation is verified, aesthetics of the face, facial support, phonetics are evaluated. Last but not the least, the comfort of the patient, the new setup is analyzed. With the new setup, during the try-in procedure, we'll calculate the vertical dimensions by keeping all these measurements, and like facial measurements as a guide, by keeping by phonetics as a guide, and using all these methods, we can determine the vertical dimension at the time of the try-in procedure also, and we can verify the previously recorded one. So in this way we recorded the vertical dimension. Those were the methods to record the vertical dimension. So what all methods we discussed? Methods were the facial measurements, phonetics methods, and with all these methods we determine the vertical dimension. So what if it not recorded properly? What will be the effect of increased vertical dimension? If it is increased, if the vertical dimension of occlusion is more, if there is less of freeway space, and it is encroaching the vertical dimension with the vertical dimension of occlusion dimension is encroaching the vertical dimension of rest dimension, then there will be increased vertical dimension. So freeway space is less than normal. So in this, what will be the effect? Discomfort to the patient, trauma and pain under the basal seat area of the dentures, because teeth coming into contact sooner than expected. There is no time of rest, and the teeth are coming into contact again and again. They can cause discomfort and can cause bruising of the mucosa, trauma of the mucosa, and the loss of freeway space. So muscular fatigue can occur of any one or the group of the muscles of mastication, and therefore it will be uncomfortable for the patient. Muscular fatigue can result in pain. Clicking sound. So when occlusal vertical dimension is increased, opposing cusps frequently contact with each other, and it will produce the clicking sound. When the patient is normally is talking also, that we can hear the clicking sound of the teeth coming in contact with each other. Elongated appearance and at rest, the lips are parted. Patient tries to close them together, producing expression of strain. So elongated appearance, like the patient tries to close the lips, because in the rest position also lips are parted. So patient tries to close, and therefore expression of strain. Appearance is affected, and bone resorption, continuous pressure, bone resorption can occur, loss of retention stability. Leverages are caused due to premature contacts. Further loss of ridge leads to loss of retention and stability. Generalized hyperemia. Space between the teeth is essential when the mandible is stressed. If no space is present with the teeth, it will result in generalized hyperemia. Space between the teeth is essential when the mandible is these inflammation means inflammation of the mucosa. See this, you can see the excessive vertical dimension produces a strained appearance of the mouth. In this, patient is trying to close his lips, and therefore strained overall appearance. Effects of decreased vertical dimension, if we have not recorded again the properly vertical dimension rest properly, and there is a decreased vertical relation, the decreased vertical dimension, that's occlusion, dimension occlusion is far lesser, the freeway space is more than 2 to 4 mm. Then it will the effects will be inefficiency. Pressure which is possible to exert with teeth in contact decreases considerably with overclosure, because muscles of mastication acting from the attachments have been brought closer together. Muscles are closer together, so inefficiency will occur. Cheek, tongue and lip biting will occur. Loss of muscular tone as well as reduced vertical height. The flabby cheek tend to become trapped between the teeth during mastication. Appearance. The general effect of the overclosure and facial appearances of increased age because of the closure approximation of nose to the chin. Soft tissue sag and the pollen and the lines on the face are deepened. See this, vertical dimension is decreased. So vertical dimension is decreased. So there is a sagging of the skin around the corners of the mouth, around the lips, and that this sagging of the cheek can also result in cheek biting or angular cheilitis. And this can result in inefficiency. The patient functioning will be affected. Appearance will be affected properly, because with the result in because of edentuliousness, patient appearance is mostly is affected very badly, because because of the sagging skin and the approximation of the nose to the chin, soft tissues are sagging and fallen, and the lines of the face are depressed. So with the dentures, support of the dentures help us to restore all these appearances problems. But inadequate, and if we have decreased vertical dimension, then inadequate lip support result in flat upper lip. So again, we will land up with the same issues. Angular cheilitis, reduced vertical dimension, result in crease at the corners of the mouth beyond the vermilion border, and thus a deep fold will be formed, become bathed in saliva, and this it can lead to infections and soreness. Pain in temporomandibular joint. Overclosure may cause pain in temporomandibular joint due to strain of the joint and associated ligaments. Also, we can see the Costin syndrome can occur in the patients with the reduced vertical dimension. There will be tendency to push the tongue towards the throat. Adjacent tissues will be displaced, which may result in occlusion of the eustachian tubes, which will interfere with the function of the ear. And you can hear the tinnitus or snipping noises in the joint, tenderness to the palpation over TMJ, dryness of the mouth, and various neurological symptoms like burning or picking sensation of the tongue. Also, the over the years, as a result of resorption ridges and abrasion of denture teeth, there is loss of occlusal vertical dimension. So the lower jaw over closes in forward and upper direction, and the patient appear prognatic. And this will also result, the same appearance will result, prognatic appearance will result with the reduced vertical dimension, and it also can cause Costin syndrome because of the blocking of the eustachian tubes, which would interfere with the function of the ear, and you can patient will cause the it will cause the ear discomfort and the impaired hearing. See this aging effect of the patient. So restoring the we are restoring the aging effect which are caused due to edentulousness. So if there is insufficient vertical dimensional occlusion, then we will not be able to restore it, and it will result in aging effect more. Now concluded, there is no precise scientific method of determining the correct vertical relation. Registration of vertical relations depends upon the clinical experience and judgment of the dental surgeon himself. So how we recorded the vertical dimension. So let's revise all the points. Like vertical dimension is divided into two parts. It's a very important step in the jaw relation, and it is of two types: rest and occlusion. Rest is determined at the physiological rest position. Physiological rest position is the position when all the muscles of the mandibular musculature are in a state of tonic equilibrium, and this is affected by the posture, this is affected by the gravity. So all these factors, keeping in mind all these factors, we will determine the physiological rest position. And physiological, as we determine the physiological rest position, so that is the position will be helping us to determine the vertical dimension of occlusion, because vertical dimension of occlusion minus freeway space is equal to the vertical dimension of rest minus freeway space is equal to the vertical dimension of occlusion. So freeway space is equal to is 2 to 4 mm, and vertical dimension of occlusion is 2 to 4 mm lesser than the vertical dimension at rest. So how we will record this? We will record this relation uh, by keeping like the facial measurements as a guide. Like we'll put the uh, like adhesive tape, or some marker points on the tip of the chin and the tip of the chin and the tip of the nose, and then we will measure these measurements by asking the patient to repeat the sounds like the letter S, sounds like M, Ram, Ram, and then as the patient stops, asking the patient to continuously talk, and as the patient stops talking, asking the patient to open and close the mouth, tactile sense method, and as the patient stops, then we'll quickly calculate the vertical dimension of rest, and it is not the position which is maintained for a longer period of time, so we need to calculate it quickly. By these methods, we'll calculate the vertical dimension of rest. So, and also the vertical dimension of occlusion can be calculated like the by using the pre-extraction photographs, pre-extraction radiographs, and pre-extraction records can be used as a guide in determining the vertical dimension of occlusion. Like the ridge relations mechanical method can be used, using the incisive papilla and the parallelism of the ridges. And in the pre-extraction records also we can use like the articulated cast and the all the pre-extraction radiographs and photographs, and they can be used as a guide in determining the vertical dimension of occlusion now after extraction. And then we can use the phonetics method, like the Silverman closing space in the closest speaking space. We'll calculate and check the vertical dimension of occlusion, if this space is present or not when the patient is pronouncing the letters like S, Z, Ch, J, and when the patient is pronouncing the letters like 33, whether the tongue is coming in between the upper and lower teeth or not. Phonetics can be used. Properly swallowing threshold, patient has to swallow continuously, and the swallowing is and during the swallowing, at the end of the swallowing cycle, the mandible comes into the physiological rest position. So these were the methods which were used for recording the physiological vertical dimension at rest and occlusion, and then we'll calculate it, and we'll occlude the rims at the vertical dimension of occlusion, and we'll after that we'll fabricate the denture the vertical dimension of occlusion. And then if it is not recorded properly, arrange the teeth at the vertical dimension of occlusion, and if it is not recorded properly, it can result in increased vertical dimension of occlusion or decreased vertical dimension of occlusion. Increased can result in overstrained appearance, can reason plain and clicking in the temporomandibular joint. It can also result resorption of the ridges, because it will produce constant discomfort, constant pressure on the ridges, soreness of ridges. It can result in all that. And if it is decreased, then it will not improve the appearance, and the appearance will be more aged, and also it can cause the blockage of the eustachian tubes, and the sagging appearance can cause the angular cheilitis, and the angular cheilitis and the cheek biting. All these effects can occur if they are it is when there is decreased vertical dimension. So this was our vertical jaw relation.